I think going back to, in general, what are the triggers or what we understand about antecedent hematological diseases going to leukemia. For several years, we had some clinical variables we used. So we know that if patients had more blasts from the diagnosis of MDS, if they had poor risk cytogenetics, those are higher risk. I think even on the clinical side, with some of the new risk models we are applying, whether it's in myeloproliferative diseases or in or MDS, we kind of refine that. So for the IPSS revised, there was expansion in the knowledge of the cytogenetic grouping. We learned things, for example, that maybe monosomy 7 has worse outcome than deletion 7, maybe higher risk of transformation to AML. Then I think, as Rafael mentioned, I think we went to the next level now, where we're going at the level of the mutation or the somatic mutations. Sometimes we don't see any alterations in the cytogenetics, but then we see that the patients acquired a certain mutation. And I think what happens, like for MDS, early on, the hallmark of the disease is apoptosis, accelerated cell death, ineffective hematopoiesis. But then there are triggers that shift the whole thing to lack of differentiation, cells, we start seeing increase in myeloblast, and then obviously of gain of proliferation. So those are the triggers that happen at the time of the transformation. We've had some patients that had clear MDS, and then their progression is to myeloproliferative neoplasm or CMML. And you look at those patients, and you can sometimes find certain mutations at that time of transformation.
So you bring up several important points, and a key one is really around risk stratification. And you were talking as you've been involved with the refining of the risk stratification in MDS. Similarly, we work to try to risk stratify our acute leukemia patient that's kind of come in to see us, or we've seen in the hospital for a consult or things of that nature. So, Raf, at UCSD, kind of your experience as we're thinking about trying to risk stratify that early patient with AML, thinking about features such as cytogenetics or FLT3, MPN1, et cetera. What are things that you kind of view in your kind of standard panel? What sort of things do you like to act on in that early setting? And then later on, we'll talk about the more refractory sort of cases.
Sure. So cytogenetics are still incredibly important. They're diagnostic in some sense if there's certain translocations are present and actually can direct therapy and decisions about transplant in and of themselves. So things like the core binding factor leukemias, for example, are defined by those translocations, and we treat those patients a little differently than we do patients who, for example, have normal cytogenetics or have the more typical cytogenetics that we see in MDS-like cases where there's loss of chromosomal material or entire deletions of chromosomes. And we still use those factors as important risk stratification pieces. Complex karyotypes, many abnormalities, are generally considered very poor risk, whereas having some of these disease-defining translocations are better risk. Now, we've gone beyond that now. We're starting to look at individual genes and mutations in these genes. And I think still, today, the standard of care would be to look for mutations in FLT3, to look for mutations in NPM1, and in many centers to look for mutations of CEBP alpha. These, again, are all mutations that define risk to some extent, with those patients having FLT3 ITD mutations, particularly if there are a higher abundance of these mutations in a patient, being at a worse prognostic risk, and CEBP alpha patients being on the other end of the spectrum, having a better prognostic risk in the absence of other mutations. Now, we know much more about the pathobiology of AML and the other mutations that are present, and we know that many of them carry important prognostic information. But until we have therapies that are really directed at those mutations, they really haven't entered our daily clinical practice.
Well, you're absolutely correct. I mean, I think as we look at this information, there's really kind of the two components. One, does it predict how the patient might do? And as we later talk about therapy, how that implicates for us, medical therapy, transplant, or the timing of transplant. It also can sometimes implicate, the selection of therapy. And AML was certainly are slowly moving from that era of, fairly uniform approach to perhaps it will be more nuanced moving forward in the future with targeted therapies if someone has a FLT3 mutation or some other component.
I think one of the also other things we don't know about is like some of the features we know that maybe allogeneic stem cell transplant is preferable. So when the risk is higher as we proceed. But I think we learned from Rafael's paper and study that patients, for example, that harbor P53 mutation may not do well even with intensive allogeneic transplant. So we are at a time, sometimes we are not sure whether offering more intensive therapies will benefit those patients. It may actually make us think in a different way, that if patients have, for example, a P53 mutation, those patients may be better with the newer drugs that can modulate P53 than going to allogeneic stem cell transplant.